In this video, we will be discussing about rheumatic fever. The term rheumatic derived from rheumatism, which means inflammation of muscles, joints, or fibrous tissues. So, it's inflammatory disease that can involve heart, joints, skin, and brain. The disease typically develops 2 to 4 weeks after bacterial throat infection, which is grouped as a beta-hemolytic group A streptococci. Unfortunately, heart is involved in half of cases. Damage to heart valves known as rheumatic heart disease. It can be categorized as acute rheumatic fever and chronic rheumatic heart disease. Let's talk about acute rheumatic fever first. Acute rheumatic fever usually affects children and young adults. It affects 3% of population after streptococcal throat infection. The pathogenesis of acute rheumatic fever is based on concept of molecular mimicry, in which our immune system may confuse between self and non-self molecules due to structural similarities between them. So, this condition is triggered by immune response to streptococcal antigens that may structurally similar to protein present in heart, joints, and skin. So, after resolution of strep throat, our immune system is still thinking that there is a bacteria in the body and attack these tissues mistakenly and cause inflammation and damage to these tissues. The clinical features of acute rheumatic fever appears after resolution of a strep throat infection. One of the most common manifestation is polyarthritis, which means inflammation of many joints, especially large ones. Polyarthritis is typically migratory, which means moving from one joint to another joint over a period of hours. Rheumatic fever also causes carditis, the inflammation of heart. The term pancreatitis refers to inflammation of all layers of heart, including endocardium, myocardium, and pericardium. Inflammation of endocardium called endocarditis also affects valves leads to valvulitis. As a result, valves become damaged and regurgitate. Mitral valve is almost always affected, sometimes together with aortic valve. During mid-diastole, rapid flow of blood through inflamed valve produce a little hemodynamic problem and a soft mid-diastolic murmur is produced called Carey-Coombs murmur. Inflammation of myocardium may affect electrical conduction pathways leading to PR interval prolongation, a sign of first-degree heart block. ECG also shows ST and T wave changes. Cardiac failure may be due to myocardial dysfunction or valvular regurgitation. Due to rubbing of inflamed pericardium, a scratchy sound is produced called pericardial rub. In addition to these clinical features, the patient may also complain of skin lesions, such as erythema marginatum. These lesions start as a red macule that fade in the center but remain at the edges. As the name suggests, erythema means red and marginatum refer to margin. It's red at margins. Other skin lesions, subcutaneous nodules. They are firm, painless, pea-sized nodule beneath the skin. There is also CNS abnormality known as Sydenham chorea, also called St. Vitus dance. It is sudden, jerky, involuntary, purposeless movements appears 3 months later after the other symptoms. The diagnosis is made by Jones criteria, which is based on major and minor manifestations. These given manifestations are major ones, and here is a mnemonic to remember these manifestations. So we write Jones like this instead of this. J refer to joint problem. Heart sign give clue about the carditis. N for nodules, the subcutaneous nodules. E for erythema marginatum. And S for Sydenham chorea. In addition to these, there are minor manifestations also. These are fever, arthralgia, which is just pain in joints without any inflammation, raised ESR and C reactive proteins, previous rheumatic fever, leukocytosis, and first degree heart block. Diagnosis is confirmed if there is evidence of streptococcal infection plus two major criteria or one major, two minor criteria. For investigations, measurement of ESR and C-reactive proteins are useful. Throat culture should be taken for presence of streptococci. Serology for anti-streptolysin O should be performed. Chest X-ray to see cardiomegaly and pulmonary congestion. ECG to see first and rarely second degree AV block. Echocardiography should be carried out to watch different heart conditions such as mitral regurgitation, aortic regurgitation, and pericardial effusion. Let's see how we can manage this condition. Aims of management are to limit cardiac damage and relieve symptoms. Bed rest. Bed rest is important as it lessens joint pain and reduces cardiac workload. Treatment of cardiac failure. Cardiac failure should be treated as necessary. If medical treatment fails, in patients with severe mitral regurgitation and concomitant aortic regurgitation, valve replacement is treatment of choice. Antibiotics. A single dose of penicillin 1.2 million units intramuscular or phenoxymethylpenicillin 250 mg 6 hours per oral for 10 days should be given on diagnosis to eliminate any residual streptococcal infection. If patient is penicillin allergic, erythromycin or cephalosporin can be used. Long-term antibiotics is required to prevent further attacks of rheumatic fever, but it doesn't protect against infective endocarditis. Aspirin and glucocorticoids. Aspirin is used to relieve the pain of the arthritis. Glucocorticoids produce more rapid symptom relief than aspirin and are indicated in cases with carditis or severe arthritis. Now let's go back and give some overview to chronic rheumatic heart disease. Chronic rheumatic heart disease develops in at least half of those affected by rheumatic fever with carditis. Two-thirds of cases occur in women. The mitral valve is affected in more than 90% of cases. The aortic valve is the next most frequently involved, followed by tricuspid and then pulmonary valve. The main pathological process in chronic rheumatic heart disease is progressive fibrosis. The heart valves are predominantly affected, but involvement of pericardium and myocardium is also occurs and may contribute to heart failure and conduction disorders. Fusion of mitral valve commissure and shortening of cardi tendini may lead to mitral stenosis with or without regurgitation. Similar changes may occur in other valves. Once the valves has been damaged, it will progressively lead to more damage, even in absence of continuing rheumatic process.